My name is Wolfgang Bauermeister. I'm an MD and PhD and board certified by the American Board of Physical Medicine and Rehabilitation. I'm the director of the Munich Pain Institute and professor at the Department of Physical Medicine and Rehabilitation at the Kharkiv National Medical University in the Ukraine. In this presentation, I would like to present my research and clinical work in shear wave elastography using the Mindray Resona 7. In the year 2000, I began my research with strain elastography because we didn't have shear wave elastography at that time. I looked at the fascia and the muscles in this image here of the low back to identify stiff areas which I call so-called trigger points because they trigger an event, and this event is pain and a decreased range of motion. And I was able to show that indeed strain elastography was working. We had a laboratory setup, very low resolution, but it worked, and I was able to show that if I apply shock waves to those stiff areas, that they soften up and that I could see the effect in the elastography. The red arrow points to the stiff area, which is dark red and black. After the shockwave treatment, the color turned bright red and yellow, indicating softness. It took many years until we had ultrasound devices which were able to do the strain elastography, and so I had to wait for a long time to be able to visualize trigger points. One major drawback of strain elastography is the operator dependency. Therefore, I designed a computer-driven actuator which took out all the variability of manual compression and decompression, and that resulted in very stable images. When we work with shear wave elastography, we are relatively operator independent. And when we look at isotropic tissue like the liver, then we realize that at whatever angle we look at the tissue, we get similar results. But this is very different with the musculoskeletal system. There we have anisotropic conditions, meaning when we look at the direction of the muscle fiber, basically we look along the muscle fiber and then we turn the probe to 90 degrees and look at a cross-section, we get totally different values. And this is a little bit more difficult to deal with musculoskeletal evaluation with shear waves. So you have to be relatively accurate, and in order to reproduce images and compare images, you have to basically use the same alignment. Why should we bother to do musculoskeletal elastography? Well, the reason is we have 13 million people with chronic pain problems, and most of them are of musculoskeletal origin. But the problem is we do not see the physical properties in normal ultrasound, MRI, or computerized tomography. For doctors and patients, seeing is believing. But when you don't see trigger points, you do not believe that they exist. Physical therapists, massage therapists, body workers of all kinds, they palpate the fascia and they palpate the muscles, they look for stiff areas, and base their therapy on those findings, but they can only palpate superficial areas, they cannot quantify it, and deep areas are hidden because the fingers can't feel it. There is a general agreement in medicine that we need to get rid of those stiff areas, but if we don't even know where they are, how can we help our patients? So in general, flexibility equals musculoskeletal health, stiffness equals dysfunction, pain, and disability. So conventional imaging assesses the structural integrity of the tissue, like tears, swelling, induration of fat, and elastography imaging assesses the elasticity, the physical properties. More and more researchers look at the role of fascia and muscle and their role in sports medicine and pain. There seem to be many factors which influence the stiffness of fascia. One major contributor can be stiffness through overuse in sports or through work or, for example, through surgery. These are factors which can lead to tissue injury. The next factor can be neuromuscular disease, which can lead to the development of trigger points in the fascia. Cross-linking and fibrosis can be another important contributing factor to fascial stiffness. Now let's look at the elasticity of muscle. So overuse is the major contributor to dysfunction, pain, and disability. And the reaction to overuse is a neurogenic inflammation. Since we cannot separate fascia and muscle fibers from each other, we have to look at them all together, and this is what we can do with the shear wave elastography. Even though neurogenic inflammation is the basic reaction of the body to any type of injury or organ illness, most doctors don't know anything about it. They oftentimes don't even know this term. When we deal with small areas of neurogenic inflammation, we call them trigger points, and if the inflammation is in large areas, we call them trigger areas. When we overuse the muscle, then this is being registered like a noxious signal, which then gets registered by the nociceptor. As a result, substance P, calcitonin gene-related peptide, and somatostatin is being released from the nociceptor. As a next step, plasma permeates through the blood vessel walls, resulting in edema. Next, bradykinin and prostaglandins are released. The inflammatory substances sensitize the nociceptors, so they become overly sensitive. Already very small stimuli cause pain. The initial edema that was pointed out by point 1 causes a compression of the blood vessels, especially the venules, which then decreases the blood circulation and causes through the accumulation of protons and acidosis. Acidosis is very important because the higher the acidosis, the more pain signals are being referred to the central nervous system. Let's take a closer look at myofascial trigger points. Here we see the trigger point complex with the sarcomere knot, which is a contracture of the muscle fiber. Contraction means the muscle fiber contracts, but it doesn't release like it should when you stop using your muscle. The sarcomere knots have a size of 100 micrometers, and so 10 of them would already sum up to 1 millimeter, and already 200 micrometers you can see with the ultrasound elastography. 100 sarcomere contractures lumped together already make a 1 centimeter knot, which you can easily palpate. Most of us have those knots in the neck-shoulder area. As you saw on the previous slide, the inflammatory substances, bradykinin and prostaglandin, they sensitize the nociceptor. The sensitization of the nociceptors lead to allodynia, which means normal activity causes pain and dysfunction, like discoordination, for example. Simultaneously with that, we get what we call central sensitization. Central sensitization is a process where an accessory nervous system is being activated. And due to that, we get so-called referred pain. So the pain is felt not at the origin, at the trigger point. No, it's felt in another part of the body. Therefore, it's very important to know where are the trigger points, because they are not there where we feel the pain. This slide here shows a typical trigger point chart, which you can find in the literature. But don't make a wrong assumption. There where the axes are supposedly trigger points, but they are individual in each person. So the same pain doesn't have the same trigger points necessarily. So you have to look for them. This is why the elastography can be very helpful to identify those trigger point areas. Here we have headache with neck pain, can be even migraine headaches. Then we have neck pain and pain going down between the shoulder blade and the spine, which happens very often. We have pain between the shoulder blade and the spine, going into the shoulder, even down into the fingers, looking like a C6 radiculopathy. We have buttock pain. We have sciatica type of pain, but the sciatic nerve is perfect and there is no root lesion. It's all trigger points. We have a lot of substrates of stiffness in the fascial muscle, but the common denominator are the trigger points. To support this notion, we even have an animal model for the development of myofascial trigger points. There is a hypothesis that a continuous relief of acetylcholine leads to development of trigger points. Therefore, in a first step, the motor end plate was blocked, so no acetylcholine would be taken up from acetylcholine esterase. As a next step, the gastrocnemius nerve was stimulated with a frequency of 1 Hz over 30 to 60 minutes. So the outcome was not as expected. The expectation was that around the motor end plate, trigger points would develop, but that was not true. But what was found is a lot of muscle fiber tears and so-called sarcomere contractures, as you saw before in the trigger point complex model. To prove that trigger points are related to neurogenic inflammation and that the area around trigger points has a neurobiochemistry, a microanalytical measuring of the biochemical milieu was done. A defined dilution was pumped into the trigger point area, and in the outflow catheter, the dilute was analyzed over a period of 30 minutes. After about 5 minutes, the pH was as low as 4.3 and very high levels of all the substances of neurogenic inflammation were found. As stated before, the trigger points are not the areas where the pain is felt. So trigger point sites and pain sites are not identical. Therefore, when we have pain, we have to find the trigger point area where the pain is coming from as referred pain. We have different methods to measure stiffness of tissue, but the best method I find is to use elastography because what we measure we can see. In the scientific literature, we find a lot of stiffness values, but how valid are they? What are the differences depending on the manufacturer of the devices? How do they process the images? How do they generate them? What effect has the push beam frequency and the varying intensity? The size of the region of interest is very, very different from teeny tiny small to large like we have with the Resona 7. A lot of researchers exclude stiff areas like trigger points because they do not know how to interpret them, since they don't know trigger medicine. Then nobody looks at what's the minimum, what are the maximum values, and what are the number of trigger points. Those are all things we need to consider in order to get a better understanding of how we can use shear wave elastography. When we look at the mean ranges of stiffness in the literature and compare it to our findings in, let's say, soccer players or special forces, policemen, or in pain patients, we get very different results. So now, how do I put everything into practice? Now, I have pain patients, I have people with sports injuries, but pain in sports injuries is mostly the problem which stops athletes to perform optimally. So first, we assess the range of motion of the spine and the joints just to get a general idea of where do we have limitations. Then, with elastography, we scan the entire body. In the beginning, mostly the back line from the neck down to the feet. And we always compare left to the right because we don't know what's normal, what's not. So we use the patient as its own control. So we look for trigger areas with the highest degree of stiffness, regardless of where the pain is. And we treat those areas, and we see in the outcome that we have an average of a 98% of success with chronic pain patients and with sports injury patients when no other therapies have helped before. In the next visit, typically 1 week later, we check the areas which we treated, if we still find the trigger points, and then we check other areas to determine where we have to treat. We continue the treatments in weekly intervals until the patient feels better and we find that most trigger areas are gone. Typically, we treat about 20 areas within 10 visits. So it takes around 2 to 3 months to get a patient better. Besides the clinical work, I have several research programs going. One is with young soccer players at the age of 15 who are members of the football club Bavaria in Munich. They want to become professional soccer players, and this program is designed to lay the groundwork for follow-up studies to be able to identify when do injuries occur. Mostly we deal with overuse injuries, and we hope with the help of the shear wave elastography to identify markers which show us which player is at risk. Another research project which is underway is with special forces of the police. We have 70 policemen there who have to carry heavy armor, have a very high workload, do a lot of sports, a lot of training to be fit, and then they do in their free time even excessive sports. So this is a very interesting population, and we look at a number of muscles. Then they go through a mobility routine program of 3 months, which has been finished, and we are looking at the results before and after. Now, what kind of images do we get when we do the shear wave elastography? Here is an example of the upper trapezius, where we compare the left to the right side. It's obvious already from the colors that the left side has significant more areas of stiffness compared to the right side. And so we have a mean of 61 kilopascal on the left and a mean of 30 kilopascal on the right side. If this is a patient with back pain, upper, middle, or low back pain, neck, shoulder, arm pain, or headache, the left trapezius area would be the one which we will treat. In this slide, we see the thoracolumbar-fascia and the erector spinae muscle with significantly higher stiffness values on the left side. Once again, if this person has upper back, middle back, low back, sciatica type of pain, knee or heel or hip pain, this could be an area where we would go with our treatment. But since this was only one part of the puzzle, we looked at other areas of the body too, and we found a significant degree of stiffness in the quadratus femoris muscle on the right side. Since the shear wave elastography was not able to reach the quadratus lumbar-femoris area, we used the strain elastography, and there were stiffer areas on the right compared to the left. After I treated the right quadratus femoris muscle with repetitive peripheral magnetic stimulation, the result was that we had a significant decrease after 2 days in the left thoraco-lumbar-fascia. The stiffness went down from 47 kilopascal to 12 kilopascal. And remember, I did not treat that area, I treated the right quadratus femoris. The quadratus femoris is located in the buttock area. It's between the ischial tuberosity and the trochanter major. In conclusion, I hope that I was able to get the message across that elastography can identify trigger points, and that this diagnostic method can be used to base a therapy on it for pain problems and for injury prevention.